Great examples. Oh, we all remember back in our schooling days, and we were overwhelmed by the amount of tests and procedures and questions that were meant to all fit in with every patient to complete a full exam. And we're thinking, how in the world am I going to get through all of this in my 40 minutes or 45 minutes or an hour long examination? And so obviously, from a practical standpoint, hopefully this book could help the seasoned and veteran clinician get more and more honed in their ability to use the patient's history to direct where I need to spend time, and use these kind of tests and the evidence to suggest that we should use some versus others to help hone. Can you talk from just illustrate in your own mind a patient that you've seen and you think, okay, here's an example of, as we grow as a clinician and using good research to support some tests versus others, how we can see ourselves get a little bit more comfortable with knowing that I've given a good exam. I haven't tested everything, but I've tested the things that should be tested, and I haven't wasted my time with others. Eric, you want to field that question?
Yeah, sure. I think the easiest things that jump to mind are I've worked with the last 10 years with a lot of distance athletes, right? And so bone stress injuries and stress fractures are a big deal there. There is, from a research standpoint, there's not great evidence about the tests for stress fractures. And yet, every clinician, I think, can empathize with this. Despite that fact, we have to carry on and carry forward, right? You can't just say, well, I don't know what to do because nobody's published it in a research paper. And so, we kind of, I think the person that leaps to mind and is an athlete, I won't say male or female, I'm trying to protect identity here, that had knee pain. And he's a distance runner. Well, I said he's a distance runner, and had been diagnosed with a VMO strain prior to seeing me. And I thought, well, I've been working with runners for a long time. I don't recall a VMO strain from running. Like, when does that ever happen, right? So that doesn't make sense. So you do have to use some of your God-given sense and your experience that you've acquired. That doesn't make sense. So what is it potentially? So this person runs a lot. They're very thin. It's been slow onset of pain. It decreases when they run less. It increases when they run more. And so the only test I had was the test where you shove your forearm underneath the proximal thigh, just below the gluteal, and you push down, and that's the only test I know for a femoral stress fracture, right? The only one that's been listed in the literature, and it's not listed as being very accurate. And so what we did instead was invent a test. And again, I know this is maybe not the example you hope for, because I think we're hoping that it would have been better than this. But again, I want clinicians to hear that sometimes you have to use your knowledge and what you know, and there is no special test. You have to understand that they have a higher probability of stress fracture because they run a lot. They have a higher probability of stress fracture because they're very thin. You need to ask questions about their nutrition and all of those things. So you need to do a really good history and talk about what have they changed in their training, so that you have a high suspicion of a stress fracture, and you really don't need a special test at some point. But what we did was invent one anyway, and we started to do varus and valgus stress testing. So this is where being a larger clinician helps, of the femur, which set this patient off the table and said, oh my God, that's exactly the pain that I'm having in my knee. So he pointed to his VMO, and we said, okay, you're going to get an MRI then, because we need to figure out what this is. And it was a femoral shaft stress fracture. He'd been running on for probably 3 or 4 months with the diagnosis of a strained VMO. So again, the take-home message is, despite the fact that we're talking about a textbook that I love, is that those tests are only as good as the history that you've done. So you have to really set your baseline probability of a diagnosis. If you don't do that and you just string together even the good special tests and hope that you're going to get a diagnosis that way, that isn't the message I would want to send to any clinician. That's how to proceed.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.